Welcome to Public Health in Real Life. My name is Ashwin Kadambi. I'm a senior global public health professional and your co-host today. Before I begin and introduce our two discussants, we are delighted to bring this episode on occupational health and safety in a changing global landscape. The Public Health in Real Life series is aimed to celebrate unsung heroes, inspire the next generation of professionals and public health leaders, and to educate people with sound public health information. Today, we are joined by Dr. Bobby Joseph and Dr. Tunde Esan. Before I begin with introducing them, let me welcome Dr. Maimuna Alex-Adeomi, my co-host. Maimuna, let me turn to you for a few words of welcome, and then we will get started.
Thank you so much for the introduction, Ashwin, and you have captured the channel, the series, and then the topic for today nicely. Once again, I want to welcome everyone to this episode of Public Health in Real Life series, where we'll be discussing occupational health and safety. McKinsey Global Institute recently put out a report where they estimate that about 100 million workers would have to change their jobs by 2030. And we all know that the global pandemic is reshaping the future of work. So this is a good time to start talking about what occupational health and safety means in that changing landscape of work. Welcome, Dr. Bobby and Dr. Esan.
Thanks, Maimuna.
Thank you for having us here.
Sorry. Well, thank you very much, Maimuna. Let me start by introducing Dr. Bobby Joseph. Dr. Bobby Joseph is the Vice Dean of Community Outreach and Distance Education, Professor of Community Health and Head of Occupational Health Services at St. John's National Academy of Health Sciences, Bangalore, India. He is the current editor-in-chief of the Indian Journal of Occupational and Environmental Medicine. With expertise in community health, his area of focus has been the health of workers or the subspecialty of occupational health. He has won several awards in this field at the state and national levels in India in appreciation of his work in improving the health of occupational groups. He has a long association with the plantation and apparel manufacturing industries. Welcome, Dr. Bobby Joseph.
Thank you, Ashwin. Pleasure being here. You can call me Bobby, as no need for apprenticeship doctor. Thanks.
Wonderful. So let me turn it to you, Maimuna, to introduce Dr. Esan.
Thank you, Ashwin. Dr. Esan is actually a friend and colleague, and he's an experienced occupational health physician with a demonstrated history of working in the medical practice industry. He's a graduate of the University of Ilorin, Nigeria, with a master's degree focused on occupational health, policy and practice from Cardiff University in the UK. He qualified as a member of the Faculty of Occupational Medicine, Ireland in 2016. He has a diverse experience in the manufacturing and energy sector in Nigeria, and he currently practices occupational medicine in the UK. He's an accredited physician for Oil and Gas UK, and he's also a member of the Royal College of Physicians of Ireland.
Thank you very much, Maimuna. It's nice having you here. It's nice having been on board with you, and I hope this session will go very well, and we'll be able to discuss this to the panel.
Well, welcome. Thank you very much, Maimuna. Welcome, both of you. So let me turn to you, Dr. Joseph. So can you help our audience understand what is occupational health and safety, and how is it different from employee health?
Well, Ashwin, I'd like to go by, you have a definition of occupational health, obviously, in occupational safety, obviously, in public health.
Sure.
But I would like to go back to what our textbooks have always spoken about where occupational is concerned, or define occupational health in a different kind of way. And in India, as I'm sure in other countries as well, occupational health has got four components, in my opinion. The first of which being the promotion and maintenance of the highest degree of physical, mental, and social well-being of all workers in occupation. Basically, a different take on the definition of health by WHO, but applied to the occupational setting. The second part of occupational health is the prevention of adverse effects caused by the working conditions among the workers itself. And the third is the protection of workers in their employments from factors which are adverse to health. The fourth is the placement and maintenance of workers in an occupational environment adapted to their own physical and mental needs. And I think as this discussion goes on, I will be able to give you some examples of how each of these four points are important where occupational health is concerned. But going back to what the public health perception of occupational health and safety, it's obviously the trends in illnesses and injuries in the working population and what we can do to prevent these illnesses and injuries. That would be my take on occupational health and safety. Where your question was about employee health, and I think the difference is that when a person comes into a particular occupation, all that organization can do to keep the person safe from each of the adverse events which can happen to him in the industry is what employee health would probably be about, and trying to identify those issues when they happen as soon as possible, so that an intervention can be done to help them out. That would be the employee health component of occupational health.
Dr. Esan, of course, with the current pandemic, what have been the current trends in terms of the changes in definition of occupational health with large number of people starting to work from home? The definition of the occupational environment has changed. So how has it changed the field of occupational health?
Thank you for the question. It has, in my opinion, it has not really changed much. We only have to define what our focus is in occupational health and what we tend to do for employees. Generally, occupational health has been evolving over time, definitely. And in the past 20 years, so many factors have contributed to what we do in occupational health in terms of globalization, new and complex, technologies, new diseases, like you rightly said, working from home. Now we have to focus on the psychological impact of work, the psychological impact of the pandemic that's having on people. And apart from that, we now have to focus on the musculoskeletal impact that working from home will have rather than working in the office. Working from home, as you can see, brings in its own challenges. So as much as it is a good way of modification of workers' practices, but it has its own challenges too. Like I said, psychological impact of being away from your colleagues, the psychological impact of not living in the confines of your home, lack of social integration. So all this combines together, and from emerging trends, mental health problem has been rising in the scheme of things in occupational health. Before we used to have musculoskeletal disease as the major problem. Now it's still the major problem. Psychological health was the distant factor to consider then, but now it's edging closer towards musculoskeletal diseases in what we actually consider in our practices. So the pandemic has brought in has brought in some changes, and bear in mind that this is just the beginning, the initial phase. Most occupational health practitioners are still trying to evolve in their practice in order to adapt and advise employers on what to do regarding the impact of the pandemic on the work environment. So that, I think, is something that future research and should be about the impact of of the pandemic on occupational health practice and on employees themselves and how we can advise employers on the way to go. I mentioned something regarding musculoskeletal disease. Of course, I mean, I've had experiences of people, of clients complaining about being crammed up at home, not enough space to do their job, not enough adequate ergonomic furniture to do their work safely. And now we're having increased a rise in musculoskeletal disorders owing to working from home due to uncomfortable or less ergonomically structured working environment. So this is under a focus that we have to put into consideration in our practice as occupational health physicians.
Thank you very much for that very elaborate discussion, Dr. Esan. I would reel some WHO stats that pertains to occupational health and safety. The World Health Organization says there are 1 billion workers and nearly 1 in 3 of these live below the poverty line of work. And they live below the poverty line of $2 a day. And of course, you know, in a lot of developing countries, the informal sector makes up a bulk of the workforce. Only 1 out of 3 countries have programs to address occupational diseases. And it also estimates that it costs about $18 to $16 to provide that personal protective gear per worker for essential interventions and health services that then prevent occupational and work-related diseases. So, Dr. Bobby, if someone asks or an organization is asking you why should they invest in occupational health and safety, what would be your response to that?
Sorry, I think there's plenty of evidence to show that whatever you invest in health, whether you're investing specifically in occupational health services like an occupational clinic, or like you mentioned in personal protective equipment, I would even go as far as saying that even provision of primary health care in an occupational setting is likely to benefit the workers. I mean, we have data from within the country, and I'm sure you and audience also would probably refer to some of the studies which have been done across the world, which have shown that a $1 investment in health services has a return of $3 at the end of the day. And I'm specifically referring to a study done by Business for Social Responsibility in Egypt, where they've shown that providing just simple health education to women workers in the factories has resulted in a $3 return on investment for every dollar spent. Having said that, even in our own circumstances in India, Ashwin mentioned that I work with the tea and coffee plantations. I do know that in the past 20 years, when we've been tracking the health services in some of the companies that we work with, we have shown that there's a decrease in sickness absenteeism, for example, and total absenteeism as well. To the extent that over the past 20 years, we've saved probably about 7 days of sick leave in these estates, in these tea and coffee planting estates, as a result of which that much more productive production takes place. So it goes without saying that any investment that you do for the worker in the occupational setting is definitely going to benefit them at large. I think, but more importantly, what you mentioned about the large proportion of workers being in the unorganized sector or the informal sector, as you called it, that would probably be the most important area where we have to target some kind of interventions, and it's very, very difficult to do anything in that setting. And I guess that in all other formal settings, definitely investing in health, be it primary care or in occupational health services, will definitely have its benefits.
Thank you, Dr. Joseph. According to the US Bureau of Labor Statistics, about 3 million workers suffer from work-related diseases and injury. And of course, they are looking to, just expand on policies and regulations that support workers' health. Is this trend, Dr. Esan, I think you had mentioned something about trends previously. So does this trend that occurs in the US entail in developing countries as well, or are there disparities in the trend?
Well, on paper, there are disparities. The problem with developing countries is that we don't really have much data to work with. So in order to bring out all these figures, for example, measuring sickness absence, or even like Dr. Joseph said, the measuring the impact, the return of investments on health. These are critical areas that would need adequate data to work with. And bear in mind that the informal sector in the developing countries constitutes a large proportion of workforce. It's actually very, very difficult to simplify. But be that as it may, um, the key thing we have to focus on is how does occupational health impact on workers' health, workers' well-being, productivity, and also on the general well-being of the employee, and also of course how does this impact on business entirely. Trend and trends need data, and um, and that's something that developing world makes. But not just belittling the impact of what professionals have done in the developing world so far so good, but I've not really seen much data to back some of the trends that we can replicate some of the trends that is happening in the developing world in the developing setting. So I think I'll leave it like that. Dr. Joseph, do you have any input on this?
Yeah, I fully agree with you, Dr. Tunde, that without doubt we don't have systems in. I'm speaking for India for that matter, but there's a total inadequacy of reporting systems in this country. That basically stems from the fact that about 90% of our workers are in the unorganized sector. Even in the organized sector, there are issues. The fact being that we don't have adequate occupational health and safety facilities. For example, even having what's called an ambulance room as per the Factories Act may be lacking in some of the factories, some of the workplaces which we work at. Added to that is the issue of trained professionals. How does a person diagnose an occupational illness or an injury? Of course, is very very obvious, but how does one say that an injury or that an illness is because of the occupation which the person is doing? So the lack of trained professionals also adds to the problem which you are mentioning, which is the lack of data in developing countries. Without doubt, that is definitely an issue which we have to contend with.
So, in terms of going, I would like to go back to your conversation about the tea and coffee plantations, Dr. Joseph. How can we create change in those sectors? So we are assuming that mostly those are in the informal sectors of economy. How can we bring them quality occupational health and safety? And or does it already exist? Or what kinds of improvements need to come to that field?
Yeah, so Ashwin, actually, we are lucky that the British left us with the Plantation Labour Act way back in 1923, if I'm not mistaken, and most of the provisions there were kind of tailored towards people migrating from the plains to the hills where these tea and coffee plantations exist. And though the Plantation Labour Act does very very clearly mention what those welfare activities which the estate is supposed to provide. So, having said that, in the organized tea and coffee plantations, and you're right in saying that there are a lot of unorganized or very small farms where you won't get these kind of services. But the larger corporates which organize these estates, they have pretty robust health systems in place. And having said that, because we are dealing with the population who are living in a kind of a closed environment, a closed population, if you want to call that as such, they often have to deal with non-occupational diseases before they actually have to start working with occupational problems itself. Because you'll have issues of infectious diseases. I mean, historically, about 50 or 60 years ago, malaria was rampant in these estates. Childhood illnesses like acute respiratory infections, diarrheal deaths, cholera, all these were quite common on the tea and coffee estates. We've kind of solved all those issues now, but we still have issues with, let's say, maternal health or nutrition of the workers, or like Professor Tunde was saying, musculoskeletal disorders. These are common problems which you have to contend with in the tea and coffee plantations. But the system there, at least in the organized corporate run tea estates, is that they have the wherewithal to take care of those kinds of issues. But just to reiterate the fact that very often you're dealing with non-occupational diseases in these settings, and not necessarily people who come with problems of the work which they do.
Thank you, Dr. Joseph. And Dr. Esan, can you expand on the piece in terms of access to health services for in the sub-Saharan African region, where we have the same kinds of conversations about informal economy, and there's of course there's not they have difficulties even to access primary healthcare in those areas. How do we go about driving policies, whether it is at a local level or a central level or the regional level in the African subcontinent, in the African continent? How do we drive occupational health and safety and make that a part of the national health policy in each and every country?
Yes. Like I said earlier, without belittling the efforts of professionals that have been doing a great job in instituting occupational health practices in Nigeria. I mean, when I was in Nigeria, we have, and it still exists, a very vibrant organization that has tried as much as possible to put occupational health in the front burner within the government coffers. I'm talking about the Society of Occupational Health and Occupational and Environmental Health Physicians of Nigeria. This wonderful association have done a very good job in bringing occupational health practices into the front burner. And I'll tell you one of the ways in which we can enhance occupational health practices is Nigeria. And the key thing is to develop manpower. There's a dearth of manpower in occupational health practices. The technical know-how is deficient, and we need to develop a critical mass of people, of professionals that are adept in and are skillful in occupational health practices, introducing training to healthcare professionals, creating awareness, introducing postgraduate trainings. In Nigeria, postgraduate trainings are now coming up in occupational health, which is a good thing. And also, we need to create awareness for government to be involved, because occupational health is largely legislation driven. Without adequate legislation, you cannot have an effective occupational health practice in the country. And I'll give you examples. Even in the UK, most employers, what really drives them to key into occupational health practice is actually they look at it from the financial framework, from the legal framework, and from the moral framework. The legal framework and the moral framework in order to build the profile of the company is one of the key things that drive most companies into operational practice. Apart from the financial benefit of doing that. So this is not this phenomenon too is not absent in the developing world. So we need to drive the legislation. We need to have the adequate legislations in place to back up occupational health practices, because that's what actually drives it. Most employers will, on a regular day, especially in the third world, will not want to institute occupational health practices because of the perceived cost. When I say cost, the perceived cost involved. But with awareness, more training of more professionals, not just doctors, because occupational health is a multidisciplinary specialty. We have multiple specialties that constitute occupational health practices. We have doctors, nurses, physicians, psychologists, physiotherapists, occupational therapists, occupational technicians, workplace well-being practitioners. So there has to be that critical mass of technical know-how to drive occupational health practice, and also adequate legislation. Adequate legislation that is enforceable to make occupational health practice stand out, and also to impact on workers, on the general workforce.
Absolutely. So, Dr. Esan, I would like to continue with you before going back to Dr. Joseph. Okay. I know you touched on this a little bit earlier, but when people talk about or think about occupational health and safety, they're thinking about factory accidents, for people working in the manufacturing sector, and then for in the plantation sector, people think about injuries related to snake bites and other animal-based accidents. So, in addition to that, what other areas are usually neglected when it comes to occupational health and safety?
Um, that's a big one. But I'll try to simplify it as much as possible. First, occupational safety covers the risk factors in your workplace. Okay, so you have to have a risk assessment to determine what are the risk factors at the workplace. The potential safety hazard that could possibly cause injury. Those are the things that occupational safety covers. So you have to identify what applies to your workplace, and but generally, um, generally speaking, areas of neglect, uh, people, I mean, employers, especially in the third world, like I said, without adequate legislation, they tend to put us in the back burners and in the back burner. So, sickness absence management is one of key areas that's always been neglected by employer, and the impact of occupational health practice on sickness absence management is one key area, and also even right from the basics, basics of bringing in employees into the system, uh, fitness to perform your duties, your medical fitness perform your duties. People, employers will just recruit people and without ascertaining whether this person is fit for the job.
I think we might have lost Dr. Tunde. Meanwhile, Dr. Joseph, I think if you can also touch on those pieces, but more importantly, one widely spoken topic today is health worker burnout. And how would that be part of occupational health and safety, or and also can you touch about other neglected areas in occupational health and safety? Thank you.
Yeah, so going back, before going on to the health issues faced by the healthcare workers, going back to the issues which you initially started the discussion with about issues in the factory and work settings, I think an important component which is coming up quite significantly in practically every single industry is mental health, and the absence of trained professionals to deal with mental health issues. I mean, the fact is that most people would probably bring the issues they have at home to work, and vice versa as well. The issues they have at work go back home. So when a person has issues at home and comes to work in a bad frame of mind, how do we deal with that? You know, and we don't have the wherewithal, we don't have the trained personnel to identify those kind of issues in the work setting and provide solutions for that. So
Yeah.
that I think is going to be a big challenge over a period of time, which is, you know, and we know that mental health issues are increasing in as much as injuries are decreasing. In the US, for example, there's a downward trend for injuries, but where mental health issues are concerned, they are on the rise, and pretty much similar situation in India as well as in other Southeast Asian countries. Going back to your second question about, you know, what are the ways in which you can deal with worker burnout, especially in the healthcare industry or the healthcare setting. I think we have a framework in place. We have what's called the hierarchy of controls in place, which is a good guideline for us to go back to when we have issues related to any health problem in a work setting. And the application of the same hierarchy of controls in the healthcare setting is probably the solution which we have in mind. It's difficult to eliminate the risks or the hazards which are present in the healthcare setting. It's difficult to substitute some of the work which we do, but there are possible engineering controls and administrative ways in which we can deal with health issues in the healthcare sector. I think the point though is we have to think out of the box. For instance, we published a study some time back looking at burnout in emergency room professionals, you know, and we find that it's quite high. Is there a way in which we can tackle that? I mean, typically physicians in the emergency room work for 8 to 10 hours continuously, bombarded with patients who are coming with all kinds of health problems. So what can we do to sort that out? I mean, what I'm saying seems very simple and simplistic, but then is it possible to give them a shorter shift? Give them a 4-hour shift and a 4-hour break after that, and then followed by another 4-hour shift. So we have to probably think out of the box and see what we can do to alleviate these problems which healthcare workers go. And I'm talking specifically about burnout. I'm not talking about the other biological hazards which healthcare workers face as well, which is what we're dealing with in the COVID situation. So I think that's most important. Giving the workers space to take a break, maybe to relieve himself of some tensions at work and come back to work in a better frame of mind.
Thank you very much for that very elaborate and enlightening response, both of you. Dr. Esan, you've continuously said occupational health and safety is a largely legislative-driven field of practice. So in your experience and just from studies and all, are there, for lack of a better word, punitive measures that are put in place when organizations don't adhere to set legislation and regulation concerning health worker and safety?
Sorry, let me apologize. It seems my system went off here when I was speaking about the last question, and I think Dr. Joseph has done a very good job talking about that. Now, regarding punitive measures, experience have shown us that applying punitive measures to occupational health practice has not really worked so far so good. But that said, there can be punitive measures from regulatory agencies to organizations that flout occupational health rules and occupational health and safety rules. There are regulators in the UK. We have the health and safety HSE regulators. We have that regulates occupational health and safety practices. It's not normally encouraged within a setup. It's not normally encouraged to apply punitive measures to occupational health practices because it has its own problem. It comes with its own problems. I mean, people have to adhere to occupational health and safety practices because they really believe that it will impact on their health and impact positively on their health and well-being, prevent workplace injuries, and also add value to the organization. That said, the UK encourages, for example, in the UK, they encourage companies to report dangerous diseases and injuries that occurs during at the workplaces. Not because they want to punish the organization for having that, but as a means of gathering that data and also to reviewing such occurrences and ways to prevent it from happening in the future. So that should be the approach, not from the punitive angle. That should be the approach to how to review the existing structure in order to prevent future injuries from occurring or illnesses, work-related illnesses from occurring at the workplaces.
Thank you so much, Dr. Esan. Dr. Joseph, the recent Glacier disaster that happened in India took about 32 lives and counting, and as of the last report, there are about 165 again and counting missing. Some people claim this because of the glacier breaking off of the mountain, that it was due to climate change. Some other people accuse of, or at least they state that there were poor occupational health and safety practices in place, at least in the response. As an expert in that region, what is your take on it?
I think if you look at the NDMA guidelines and the National Disaster Management Authority guidelines, I think the focus, or they stress on the need for monitoring prior to, during, and after the construction of infrastructure. So I guess that has probably not been done in this thing. I'm not so qualified to talk about that, but I think that a risk reduction has to start with identifying and mapping a potential disaster-prone zone. So we do that very often, let's say in cyclone hit zones or earthquake-prone zones of the country. But this, I think, has been, I would attribute it more to, let's say, climate change than necessarily a failure of the occupational health services. Well, at the most, I mean, we could have predicted that, or probably sensed that something like this is likely to happen because of the situation where, or the location where this dam was being constructed, or the tunnels have been constructed. But I've been through some of these tunnels and some of the work which I've done. It's unimaginable what a person can do in case there's a disaster in that place. It's something like working in a mine, in a mine, for example. Let's say in a coal mine, where let's say the earth collapses, so there's a landslide. People are trapped there for ages, right, for days together. So I guess that's something which happens in this kind of a situation. I would go to the extent of saying that it was an act of God, and the result of which was because of which the waters came in, and water from underneath the glacier just poured into the places where the tunnels were being constructed, and therefore it created a major disaster. So it's difficult, but I guess with advanced planning and probably putting in place emergency evacuation plans and provisions that should be in place for people to get out in case there's even a trickle of water coming in from one of the sites. Those were things which could have been done. So I wouldn't go as far as saying that it was an occupational health and safety disaster. I would think that we were probably a little unprepared for what happened by this act of God.
Absolutely. In some news reports, they were saying that the family members of the workers who were affected were not notified right after the incident occurred. And that was highlighted as a gap in occupation and health safety. So something as simple as taking the emergency contact of the workers when they start working, and updating it at a proper interval. Do you think such simple interventions could, at least not only save lives, but get the word out to people so that more rescue members can be part of the response?
I guess, Ashwin, from what you're saying, I guess we have to be prepared for any eventuality in any work site, right? And that is a little difficult to set in place, especially in a country like India. We also know for certain that much of the work which happens in the country, there are migrants who are doing this kind of an activity. So going back to your point about whether the family members could have been contacted, maybe a little difficult because most of them, I'm not too sure. Like I said, I don't work in that particular geographical region, but I'm presuming that many of the people working there are migrants, and they're the ones who are doing all the difficult jobs which are to be done in this kind of a sector. So so much of you can say that the nearest contact or the easiest contactable person should be listed in the worker's work profile or in his job profile. But yeah, it doesn't happen even in other settings for that matter. Even in formal settings, it's probably not happening, Ashwin. So a little difficult to give a strong comment on that.
Got it. And I would like to shift the conversation a little bit, and would like to just get your would like to understand what motivated you to go into this field. So maybe I can start with Dr. Esan, and you can share what motivated you to get into occupational health and safety. Sorry, there we go.
All right, yeah. Well, that's a very tall question for me. Frankly speaking, for a very long time after I finished medical school, I didn't really know what I wanted to do in terms of specialty. But I'm actually when I look around myself, when I look around my environment, see the conditions under which people work, and also the fact that workers' health seems to be at seems to have been seems to be relegated to the background where I come from. Mostly mostly because of so many multifactorials that we will not be able to discuss on this platform. I look at what I can do to impact positively and to impact positively using my knowledge. Um, then I had a friend that invited me to a program organized by the Society of Occupational Health and Environmental Health Physicians of Nigeria, and I was intrigued that there's a specialty that actually take workers' health as a priority that can actually make help employers plan for their workers' health, and that can actually also push the workers' health to be in the front burner of the national discourse. So I got interested in this specialty, and from then I was actually training as a public health physician earlier. I I left the training and pursued my career in strictly in occupational health, and I've not looked back since then. It's a fantastic and interesting specialty of medicine. Although people don't, the specialty is not as popular as all other specialties, but I find it very interesting. I find it very intriguing in the sense that, I mean, we tend to relate with multidisciplinary set of professionals in order to impact on positively on workers' health. So that has been that was actually my drive to go into the specialty, and since then I've not looked back. Yeah.
Awesome. Dr. Joseph, how
Yeah,
about you?
so
What motivated you?
yeah, so Ashwin, probably a little late in the day to make a confession, but honestly, I'm more of a community health physician than an occupational health specialist. It so happens that our Department of Community Health in the college I work in St. John's Medical College, Bangalore, was doing some work already in the tea and coffee plantation sector. We had an association with the London School way back in 1974-75, and we were constantly working with the tea and coffee plantations. So, but having said that, I think the occupational setting gives you a fantastic opportunity to practice your public health, your community health services, right? It does have specialties like we kind of referred to a little earlier, like toxicology and industrial hygiene, which is a little more difficult to do in the kind of work which I'm doing. But the fact that you can provide community health interventions in an occupational setting like a tea or coffee plantation or in an apparel manufacturing industry, or for that matter, even in the health sector, is kind of feels a lot of very rewarding, because that those simple interventions help change lives of people, and that is what keeps you motivated. When someone comes back and says, doc, the other day when you came here, you spoke about nutrition, and now I've changed my lifestyle. I try to walk 30 minutes every day. And that's not occupational health, but it's definitely contributing to the health of the worker. So I guess that's where I get my
Sure.
things from.
Could you share any examples of something like that from the occupational health experience? Like,
Um,
for example, of a simple intervention that has made a profound change, either from your life or in the history of occupational health.
Sure. I mean, in our practice, uh, I mean, I'm not sure how many people are listening to this, but if people were to Google business for social responsibility, and within business for social responsibility, there is a program called the HER project, Health Enables Returns project. So the Health Enables Returns project was conceived in the Department of Community Health where I work at, basically looking at ways in which you can provide simple health education to workers in the apparel manufacturing industry. 80% of the workers in this industry are women between the age of 18 to 25. So reproductive health, nutrition, all those are very important topics which occupy their minds, I'm sure, for a significant period of time. So providing them with interventions, training them on simple things like what is good nutrition, kind of heads on. So I can give you a number of examples of going back to the factories where a woman comes up to you and says, what you mentioned the other day in your training program has made so much of a difference to me, and the kind of food which I cook at home, the kind of meals which I prepare for my family, all that has changed, and it's having its positive impact. More recently, I think we are running a project on. We know for certain that we don't have adequate number of mental health professionals in the country itself, and how do you get mental health to the factory shop floor? So what we've done is to train middle-level workers, supervisors, hostel wardens on identifying mental health problems, and we have anecdotal evidence of at least half a dozen suicides being prevented in these factory settings. So when you look back at those stories of workers coming and saying, this your intervention has helped, it definitely gives us some amount of satisfaction in this field.
That is outstanding and enlightening, Dr. Joseph. Thank you so much. I will turn it over to Maimuna.
Thank you so much for sharing your stories, Dr. Esan and Joseph. It actually is the perfect segue for the next question. You had both mentioned a limited number of occupational health practitioners or professionals. And I think, as with other healthcare fields, this one specifically has some unique set of challenges in the sense that, one, in a lot of developing countries, there really isn't a very defined pathway to accreditation because it's loosely defined. And then also some people don't just really understand the services that are rendered, that field of occupational health and safety. So starting with you, Dr. Esan, how do you propose to bridge that gap or those gaps?
Like I said earlier, then there has to be a well-structured plan, a conscious effort to improve occupational health practices, and especially in the developing world. The work is in the pipeline, and we've made when I was when I was in the when I was one of the national executive committee members of the Society of Occupational Health and Environmental Physicians of Nigeria. We've made so much submissions to government and to the Ministry of Health and Labor on how to improve occupational health practice. We went as far as to pushing for a postgraduate college specifically for occupational health practices. And these are the kind of inputs that we've had over time in trying to bring occupational health practices to the front burner in Nigeria. The death of personnel gap needs to be covered, and this will not happen overnight. This will take time to train professionals. Right now, most people with qualifications or training in occupational health add their training and qualifications in foreign countries. It will be good to have the critical mass of people being trained in Nigeria. I was happy when I saw an application, an advert for a master's program in occupational health from the University of from a university in Nigeria, which is good. Okay, so that's one of the ways in which we can bridge the manpower gaps in occupational health practices by bringing in professionals to come and train people, and also we also need to create awareness about the specialty. I must confess that even among health professionals, when you talk about occupational health, some will ask you, what are you doing? I mean, what specialty is that? I mean, even among health professionals. Okay, so we need to actually create that awareness. In where I come from, occupational health is treated as a sub-specialty under public health. So occupational health does not have a college of its own, and that's, like I said earlier, that's one of the things that the association was pushing for, in order for occupational health to have its own college, so that they can create awareness, train more professionals, and also put occupational health in the front burners of the national discourse.
Thank you so much, Dr. Esan. How about you, Dr. Joseph?
Yeah, so Maminal, I don't think there are any easy solutions to that, especially in the developing world, like Dr. Tunde mentioned. I think let's take, for example, a country like India, and I've mentioned this earlier. We have 90% of our workers, which means about 500 million people, are in the unorganized sector. So how does occupational health reach them? The ILO has a way to do that, and they call it basic occupational health services. I would go as far as like Dr. Tunde mentioned, occupational health is a subspecialty of public health in this country. And if you look at the standard textbook of public health in this country, I think it's a 900-page textbook of community medicine, or what's called preventive and social medicine, but hardly about 15 or 20 pages of that are devoted to occupational health. So the training on health itself in the medical students curriculum is not that great. So I mean, if you were to ask me, improving that training for medical students is probably one of the most important interventions that we can do. Even for our public health system, I mean, the 90% of the workers in the unorganized sector, their access to healthcare is most likely to be either the private practitioners who abound in the rural setting or wherever they come from, and also the public sector through what are called primary healthcare centers. So even training those doctors to ask what Bernardino Ramazzini, the father of occupational health, mentioned, which is to ask the question, "What is your occupation?" That itself would be a big step in enlightening the medical professional with regards to occupational health. Because, like I said much earlier in this conversation, a lot of the diseases which workers suffer from are probably related to what they're doing at home, or but also an equally large proportion is likely to be because of the work which they're doing in factories. So even simply asking them, "Are you an agriculturist? Are you involved in the construction industry?" is likely to give you some clue as to what exactly the interventions should be.
Thank you, Dr. Joseph. That's really insightful. We all know the World Health Organization has designated 2021 as the International Year of Health and Care Workers. You had both mentioned earlier that some of the injuries that healthcare workers face is burnouts in addition to all the other physical injuries. So from an occupational health standpoint, what would you advocate to bodies like the World Health Organization and other regulatory bodies as the top three challenges that healthcare workers will face in a post-COVID or post-pandemic world? And how would you address those challenges? I'll start with you, Dr. Esan.
Okay, in the post-COVID world, healthcare work, the COVID pandemic. I'll start by saying that the COVID pandemic has not been too fair on healthcare workers generally. But that said, now we are trying to understand more about the illness, how it affects people, and its impact on healthcare workers. And one of the things that I would advocate for I would not say I have three points to give, as you've said, but one major one I will advocate for is to look into the mental health situation of health workers post COVID. The pandemic, because of its impact on the world, has impacted on the psychological health of especially health workers. Okay, seeing people die, watching people die helplessly without being able to offer much intervention, and also increased work hours, increased workload has affected the mental health of health workers generally. So one of the key things I would advocate for international organizations to look into is how to address the mental health impact of the COVID pandemic. Also, having adequate manpower is another issue that needs to be looked into by employers and even international organizations, advocating for increase in manpower in order to be able to bridge the manpower gap that the COVID pandemic has created over time. That's actually another area that I want to advocate strongly for, in order to protect the health of health workers and also protect the system from collapsing entirely. Strongly, like I said, the mental health impact of the pandemic is very, very important.
Thank you, Dr. Esan. How about you, Dr. Joseph?
Yeah, going with what Dr. Esan mentioned, which is mental health is definitely going to be one of the major issues in the healthcare sector for all people working in the healthcare sector. But there are two other things which I would probably like to talk about as well. Which one of which is obviously infectious diseases. Yes, COVID has come. COVID will be there for a few years. It's probably going to go away after a period of time. But infectious diseases among healthcare workers has always been an issue. You take Congo, for example, where healthcare workers have to deal with patients who've got Ebola, or more commonly, even in any developing country, tuberculosis is quite a common problem. And we know for certain that the prevalence of tuberculosis is much higher among the healthcare workers than in any other occupational group. So these are infections, probably more specifically respiratory tract infections, whether it's a common cold or any other infectious upper respiratory tract infection, or whether it is tuberculosis. This is something which has to be focused upon definitely in the healthcare sector. The third is probably a combination of both nutrition and physical well-being. And we know the long hours which doctors put in. We know the long hours which nurses have to stand and work. We know that healthcare workers very often don't get a break to have a decent meal, and they end up having junk food or probably eating a bit more than what they're supposed to be doing, and resulting in I would estimate that the prevalence of obesity or being overweight is a little more among the healthcare professionals than other sectors. Added to which is the physical fitness. They don't get time to exercise, and that can also be a problem. So these are things which we have to deal with. Like I mentioned earlier, we have to think out of the box to try and provide solutions. They're probably going to be at individual health settings where something has to be done. If a facility is available, then providing that particular health setting, providing the employees with a good gym, for example, or good nutritious meals, for example, and of course not to forget personal protective equipment to prevent infectious diseases. These are all ways in which I think we can probably provide interventions in hospitals and other healthcare settings.
And I think the risk factors are starting even from the stage of medical education, right, Dr. Joseph? Globally, medical students are the hard hit when it comes to their studies and preparing towards their profession. And but international reforms in medical education in any country sounds to be slow. And do you believe that improving if that is also an area that we need to focus on to improve the because when medical students are doing, whether they are students or they go to residencies and they work under a professor, they're basically toiling probably 20 hours a day. So probably we need reforms from that stage onwards to ensure that there's no disparities when it comes to occupational health delivery as well.
Sure, absolutely, Ashwin. I can't agree more on what you're saying. The fact also remains that we need to educate our medical students, even in their very young days, that they are going to be facing these hazards. It could be they could be biological hazards, they could be physical hazards, they could be psychosocial hazards which they could be facing. But getting them to know about these hazards and to identify these hazards when they're in the workplace is probably going to be an important thing. And I think the Medical Council of India, or what's now called the National Medical Council, has started what's called the foundation course for medical students. It's just a 1-month program before they start doing their studies in anatomy, physiology, and biochemistry. But in that foundation program, quite a lot of focus is given on the mental well-being of the students. Knowing what stresses, how do they identify stress in themselves, and what they can do in case they are faced with stress. So I think small steps are being taken in that direction, and it goes without saying that we have to start young, start when they are just entering the medical profession, instead of waiting for us to do interventions when they are halfway through their careers.
Dr.
Yeah,
E,
that's it.
any thoughts? Any thoughts on that? We can go forward, Maimuna. Not a problem.
Okay. Yeah, Dr. Esan, I don't know if you can hear us. We're asking if you had any added thoughts on that piece, like really going further back in the pipeline as far as medical school to manage expectations.
Yes, I quite agree with what Professor Joseph has said so far regarding going. Of course, with any form of intervention, you have to deep dive and look at what the problem is from the base back. You have to go back to the drawing boards, look at what can be done to long-term, short-term solution, but long-term solution to the problem, the key issue that we have in the health sector that can impact on workers' health. So, I mean, sensitizing medical students from the medical school about the potential, physical, biological, chemical, psychosocial hazards that the workplace portends is one way to go, and that will actually stimulate them at the initial part of their training to 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 look into good and sound occupational health practices in order to protect themselves and also to protect their clients and patients from these unforeseen or foreseen impact of the environment on people's health in general. So that's my take on that. I quite agree with what Professor said, and it's been very insightful.
Thank you, Dr. Esan. And piggybacking off of the expectation management piece and also going outside of the health sector workforce, McKinsey Global Institute did a research recently, and they estimate that about 100 million workers would have to either change jobs or be reassigned by 2030, not just because of a post-pandemic world and the future of work, but for things like the rise of artificial intelligence, machine learning, and automated work. In preparing for that potential shift, what would be your recommendations? I'll start with you, Dr. Joseph.
Tough to predict what we are going to be doing 10, 15 years from now, Maimuna, but I think our youth, people who are going to be in that demographic in 2030, 2035, are probably a little more worldly wise than we were at that particular age. So I think over a period of time, they would understand what the hazards are going to be in those sectors, or what issues they're going to be having because of a lack of job opportunities, and they, I'm sure, will come up with solutions for that. But from an occupational health setting, it's going to be difficult for us to predict what kind of problems the youth of today are going to have in the year 2030 to 35. And all that we should be doing, or what we can do, is to be preparing them mentally to face those challenges. I don't have a better answer than that. I'm unable to predict what exactly is going to happen about 10 or 15 years from now.
Thank you, Dr. Joseph. That's still insightful regardless. How about you, Dr. Esan?
Difficult to predict. I must agree with Professor Joseph. In the past, like I said earlier, in the past 20 years, globalization brought technological, social, and organizational re-engineering to the world. And as these things evolve, our practice also will evolve. The good thing about occupational health practices is that we emphasize more on risk assessment. So when you have a situation in the future that portends that has a potential risk or has hazards to the workforce, we tend to deep dive using the risk assessment model, and with that, we'll be able to bring out logical occupational health recommendations and advice to employees on how to go about it. No doubt, the improved the trend, the workplace trend is changing. No doubt, globalization has changed things. The workplace trends is changing from time to time. Will change from time to time. The challenges we have now will not be the challenges we have over then, and that's the reason why we should prepare ourselves by having a critical mass of workforce that are ready to deal with these emerging problems as it comes as it comes to play. It's that very difficult to predict what will happen based on the impact of the technology, or we have so many things coming up now, nanotechnologies, biotechnologies. I mean, we don't really know how the cost and how this is going to really impact on what we can prepare ourselves by having a critical mass of workforce to deal with this when it comes. And like I said earlier, through occupational health is the good thing about occupational health practice is the risk assessment model that we tend to use to assess risk and also provide recommendations and advice to employers on what to do in a certain situation. Yeah.
Well, thank you so much, Dr. Tunde Esan and Dr. Bobby Joseph. It was a pleasure talking to you today. And I mean, the kinds of information you provided today were pretty thought provoking. And there is, of course, a lot of areas to discuss. Each and every area that you spoke about has a lot of contents to unpack from it. But we would be happy to share your information in our channel, and audience members can maybe reach out to you for further discussions. However, any last words, Maimuna?
No, I just want to piggybacking off of what Ashwin said and echoing his appreciation. We thank you both for your time and expertise. We've been thoroughly educated, and I'm sure our audience have also been thoroughly educated and learned from just you sharing your thoughts on this. So it would be helpful if both of you can share your preferred contact details, how people can reach you. And I'm sure a lot of people who are maybe even small and medium business owners will be interested in learning about how to keep their workers safe and how to manage some of those, like you said, perceived costs, like you said, in order to ensure that they have a healthy workforce, which I think eventually leads to a more successful business. So starting with you, Dr. Joseph, can you please share your contact details?
Yeah, sure. So Ashwin has my contact details. He has both my email ID and my cell phone number. He can use that and put that on your channel to let people know how they can contact me. But if I can just say a few words, thank you very much for inviting me. It's been a pleasure being on board with all three of you. Dr. Tunde, it's a pleasure getting on with you virtually on this mode. Maimunad and Ashwin, thank you very much for giving me the opportunity.
Thank you. Dr.
Okay.
Esan?
Thank you very much too for bringing me on board. Thank you, Professor Joseph. I've learned so much from you. I was actually looking forward to talk to you to have this discussion. And thank you, Memunat, also for bringing me on board. Yeah, I know it was short notice, but yeah, anything for you, any day, anytime. And Ashwin, thank you very much. Really appreciate having me on board too. And I hope to be able to, anytime you feel free to call upon me anytime for any of your programs. I'll be available to lend my thoughts and opinions. With regards to my contact details, I will share it with Memunat, and you can also put it in your channel.
Wonderful.
Diverse audience.
Thank you so much. I also want to thank our audience for their participation and thoughtful questions and comments. Thank you all for joining us. Be safe, be well, and we look forward to seeing you again soon.
Thank
Bye,
you.
everyone.
Thanks. Bye. Thanks a lot. Pleasure being
Thanks
with
a
you.
lot.